impressive. It's of international standards. There's a small change in the order because one of the faculty has to get back to Delhi. So we start with Dr. Armugam from Chennai, who's going to talk to us on single row rotator cuff repair.
Respected Chairperson and dear colleagues, good afternoon to all of you. I'd also like to thank the organizer and Dr. Magesh Reddy for giving me this opportunity. I'll be talking to you about single row rotator cuff repair arthroscopic. Why should we repair the cuff tears? We know the debridement alone is effective only in very short term, and there is deterioration of the clinical results over the time. It is supported very well by the literature. These are two studies. First study compared about 2 to 5 years follow-up. It's almost something similar to debridement alone. But if you go more than 5 years, the difference between the satisfaction rate between repair and the debridement is huge. So in modern era, there is no role for debridement alone in the cuff repair. So when we repair, what are the goals of the repair? We need to achieve high initial fixation strength, minimal gap formation, maintain mechanical stability, optimize tendon bone healing, so that patient have elimination of pain, improved strength, and restoration of range of movement, so that he can carry out his normal activities. Biomechanically, it has to be understood so that we can achieve the results. There are force couples which are acting both on coronal plane and axial plane that must be restored. To achieve that, we must recognize the tear pattern and restore the original anatomy. Patient selection is very important for the successful outcome. The three aspects of the patient selection. One is the nature of the tear, that is the chronicity, size of the tear, and the quality of muscle. On MRI, as described by Gautuli classification, gives the gradation of fatty degeneration and good quality muscle. And the patient factors, age, physical demand, and the motivation. If the patient is not motivated to do a good rehab after the surgery, then he is not a good candidate for you. And contraindications are advanced arthritis and comorbid conditions of the patient for the cuff repair. What are the techniques we have? The gold standard trans-ACS repair, then single row suture anchor repair, double row suture anchor repair, and trans-osseous equivalent repair. The single row arthroscopic cuff repair, the steps involved is the glenohumeral joint inspection, assessment of repairability, assess the tear and how can reduce it, and identification of tear geometry. That is very important to restore the original anatomy, acromioplasty, and greater tuberosity repair site preparation, anchor placement, suture placement, knot tying. These are the steps which are very distinct and separate steps, and we have to give a lot of attention to each step to have a successful outcome. There is no shortcut, no point in rushing it, and you stick to your own steps in each patient, then the cuff repair becomes even more easy to do, because cuff repair traditionally one of the difficult arthroscopic surgery because of the many portals, the suture management, everything. But if you stick to very simple, systematic, which is best in your hand, it really becomes enjoyable to do a surgery. And the position what we use is the lateral decubitus position, the 3-point distraction. And the portals, we start with the standard weaving portal, then we have lateral portal, then anterior portal mainly for suture management. Then we switch to the weaving portal, as opposed to a lateral portal or LaForce portal, which can directly see the tear very well. Then the anchor comes in different portal. There's a needle where the anchor will go in. Okay. And we follow the SCOI technique as described by Snyder. It based on few principles. One of them mainly is the increased anchors are not needed to increase the strength of the repair. It is the number of good sutures through the tissue which is more important than the number of the anchor. So we do match and early stitch, so we maximize the each suture. On our same suture, we have one mattress and one simple, so that it doesn't cut through the tendon. Same time, the mattress has the act as the anchor, and same suture have 4 points of passing through, and no tension anchor placed close to the articular margin. And other important thing is the bone marrow stimulation, thereby the mesenchymal stem cells from the bone marrow are released, so-called crimson duvet. Like the studies have shown by Chris Joe, if you do the bone marrow stimulation, the healing is as high as 96%. If you don't do, it's only about 64%. Also, Steve Snyder has shown biopsy after the repair, at the repair site, after the mesenchymal stimulation, it shows neotendon. Okay, and this is the example of arthroscopic cuff repair. We start with acromioplasty, almost standard in all the patients, so that also gives a good room. Then assess the tear morphology. It's not a very big tear, concentric tear, and the repairability is good, no tension. Then you place the anchor close to the articular margin. You can use bioabsorbable or metal. Then you can have various different suture passing device. This one is a clever hook. Make sure that all the lamina are passed through. Then grab the sutures and you try the Masonelli. The first one will be the mattress, the second one will be the simple sutures. The second anchor going in, then we use a different kind of suture passing device, like this one from Mytech. So different companies have different kind of sutures, so that you can go well past deep into the tendon muscle junction and place this. Then you put the knots whichever you're comfortable with, and these are the end where the nice repair of the tear with a single row, no need for 2 rows. Then we do this bone marrow stimulation at the greater tuberosity, so that release the neovascular bloods. Other important technique we need to use is the margin conversion or interval release. The tear what we see initially may not be the actual one, because if you see this one looks a very huge tear. If you try to repair as it is, lot of tension, this will definitely fail. So we need to identify and what you call the margin conversion as described by Steve Burkhardt. So two simple sutures side to side like this, then becomes manageable to repair it easily. I use like Acupass or similar instruments, just pass the sutures across, then remove the dog ear. Sometimes you may have it, then 2 or 3 depending upon the length. If you put that, then it becomes a small tear which can be easily placed back into the greater tuberosity. Again, we need to identify the tear, and you don't pull the posterior leaflet anteriorly. It's more like the L shape. So unless you identify the tear pattern, it may not be easy to reconstruct the original anatomy. So these are the end. So even the big tears can be repaired successfully with single row. The rehabilitation involves 3 phases. First, up to 6 weeks, prevention of stiffness and pain. Pendulum exercises. Up to 6 to 12 weeks, it's restore the ADLs. From between the 3 to 6 months, the pain-free overhead activities, and over 6 months, sports activities or more manual work. What is the literature if you compare the single row and double row? Various clinical studies have shown, Robert Burks comparing 20 patients on each side, followed by MRI, and no significant difference. Then this one, where about 40 patients each side, 2 to 4 centimeter tear, 2 years follow-up, again no clinical difference. Also some literature review on the basic signs on the single row and double row. This study, they studied the blood flow of the rotator cuff after single row and double row. They used a Doppler flowmetry probe used before and after the second row. They showed 40% decline in blood flow after the second row. So when you put it very tightly, there is no room for blood supply. So double row actually may not be that good. if you don't have a good tension-free repair. And this study by Rodeo, the animal model, he showed the biomechanical evaluation of strength at repair site between 2 to 4 anchors. There's no significant difference. And last one, quite recent, just came in May 2013, the systematic meta-analysis outcomes of single row versus double row. And what they've shown is double row may have a better healing rate, but is not clinically significant. It is not translated into the clinical results and may be useful in a massive or large tear. So in conclusion, single row repair is the treatment of choice for majority of cuff tears. Number of anchors is not important. Number of strong sutures are more important. Understanding the tear geometry is crucial to restore the anatomy and have a good successful outcome. No tension and minimal tension repair is required. Bone marrow stimulation improves the healing. Double row repair has not proved to be clinically superior yet. Thank you for kind attention.
Thank you, Dr. Armugam. Any questions?
Simple switches, yeah.
But you get a good slide with that, or you put a non-sliding knot?
We use for the mattress we use non-sliding knot. The simple one you have to use the non-sliding. Simple of this, yeah. Because once that's fixed, you cannot. Simple won't slide.
Preparation of the greater tuberosity, the footprint anyway you prepare. So after the repair, you actually again drill some holes.
Again, drill some hole, yeah. Because the debridement, as you know, I didn't show in this one because of time. We just you debride and we get raw bleeding only. But for to get the mesenchymal stem cells,
marrow,
like a microfracture, to go deeper. So you don't go that deep with the routine debridement.
With the routine, yeah. Thank you very much.
Thank you.
I now call on Dr. Ram Chidambaram from Chennai to talk to us on anterior shoulder instability.
Good afternoon, Chairman and colleague. Thank you for IOACON and Dr. Magesh Reddy for inviting me to this presentation. This view is from shoulder surgeon's perspective. Anterior instability forms about 1/3 of my shoulder arthroscopy practice, and this shows my journey into arthroscopic stabilization starting from 2000, moving from metallic to different knotless anchors to currently I'm using a small peak anchor for the last couple of years. We'll see summarize the principles and application by showing case examples highlighting these 4 areas of anterior instability. First, what is holding the shoulder? Bony anatomy contributes 1/3, the labrum and the ligaments, and the key to concentrate is this inferior glenohumeral ligament. This forms a hammock for the shoulder, especially in dynamic activities. So, what do you do? How do you treat acute first-time traumatic dislocation in a young active patient? What do you do here? You jump to do ACL reconstruction because of risk of re-injury, joint damage, and functional loss. On the same count, why not respect IGHL? The shoulder dislocates in a big way, big disability, and big damage to the ball and the socket in the long term to come. You want evidence? Age and activity decides the recurrence rate. We know very sure if his age is younger than 25, 80 to 90% are going to dislocate again. And you want randomized controlled trials to compare the conservative and surgical treatment. You have level 1 evidence to show a significant, huge difference if you operate. So that's the long-term follow-up, 10 years time. So in my practice, as an exclusive shoulder upper limb surgeon, I recommend arthroscopic repair. I do Bangkok repair with 3 suture anchors, achieving capsulolabral plication with the mattress sutures to recreate the bony bumper effect. This is the top view. I do the arthroscopy in the lateral position. And the inferior labral repair, 6 o'clock position, I address from the posterior route, not from the anterior. This is important to retension the IGHL attachment to the shoulder. So that's the case of 24-year-old acute first-time traumatic dislocation. You see the shoulder is reduced. You could see the IGHL avulsion nicely in the coronal and the axial images. But you see something else here. You see the superior labrum is not right, and there is fluid around the biceps. These things could be dealt with elegantly if you first time operate. So on the left, on the right hand side, you see the bucket handle type of slap lesion. That's, you see the big hole. And there is an extension of the anterior labral tear down to 6 o'clock position. So these things will be torn apart if you recurrently allow to dislocate. So that's the repair of the slap first, a 12 o'clock anchor, and the suture, a simple suture, posterior simple. And second, the rest of the anterior labrum is repaired by 3 anchors, and that's your final repair picture looking from the top view. Shoulder is, humeral head is centered, well repaired. And the patient can be mobilized, and that's the result in 3 months post-operative, achieving near full range of movements, including good external rotation, because you repair in the first time. So what happens in the recurrent instability? Things are slightly different because we have 2 more problems. The capsule, repeated dislocation, it gets tenuous, and there is a big hill sac lesion of the humeral head. You will see one after the other. Now, I told you before, IGHL capsule complex forms a normal hammock. With a repeated dislocation, this gets tenuous top. Our review of our first 104 patients in the UK showed this is one of the risk factors, a stretched or torn capsule. Since then, 2006, I added this to my repair, an inferior capsular plication with absorbable suture to retension that in case the labrum is reasonably okay at 6 o'clock position. But engaging hill sac lesion occurs in a high frequency in Indian patients because they keep it dislocating for a long time or many times before they come to attention. The previous options that have been described, well, we know that clearly it is a risk factor, but the previous options were all open surgeries with varying results. Remplissage procedure was a French term for filling in, was described in 2007. I started to use in 2008. Here we put an anchor into the hill sac defect of the humerus and repair the stretched posterior capsule and infraspinatus tendon onto the anchor, thereby exteriorizing the hill sac. So does it heal? Yes, more than 75% heal. Does it restrict motion? No. Very less significant restriction of movement because we are stretching, repairing only a stretched area of the capsule and the muscle. I do a remplissage with 1 double-loaded anchor inserted into the humeral head defect. So this is my order of repair. First, address the inferior labrum, then do the capsular plication if necessary, put the remplissage anchors in place, sutures in place, to the front, Bankort repair, go back, tie the remplissage sutures. So repair all around. So because I do this, it's very important to mobilize the shoulder day 1 post-operative with pendular movements, shoulder shrug, shoulder roll, and also assisted forward elevation to 90 degrees before they go home on the next day. It's very important. So this is an example, 25-year-old tailor with more than 30 times dislocated, easy dislocation in bed. You see the big hill sac lesion there, you could see that. And that is his instability with the finger push, it can dislocate the shoulder. So that's his arthroscopy from the lateral position. You see the huge humeral head defect, and also you see the most of the head is in the inferior gutter, and you see a very, very lax stretched inferior capsule as I highlighted before. Here I'm doing an inferior labral repair using a posterior direction, recreating the inferior bumper. You could see here the hill sac, the humeral head defect is prepared to make a bleeding area. We are not just putting an anchor, we had to make the tissue to heal to it. And here, once we put the suture, I'm pulling onto that, you see how the head is restored to the sit against the glenoids, thereby relieving the tension on the anterior labral repair. So here is a completed repair. You see the hill sac lesion repaired now. And here the movement range at the range of 1 year looks nearly similar, but I do record this range of degree abduction, and in 90-degree abduction you'd see about 10-degree difference of internal external rotation with these patients. And I always do for all recurrent instability MRI scan at 1 year follow-up to compare, see the effect of healing. Here the hill sac defect is fully covered and healed, and the labrum is repaired. So some failed surgery, they do come. So the treatment depends on whether the patient has ligament laxity, and about the glenoid, labrum, humeral head quality, effect of previous surgery or anchors, and also the demand on the shoulder. For example, here is a case, 34-year-old crane operator, had this surgery twice, failed before. This is the history, started from 1995 and ends in 2011, it presents to me. So there is a huge hill sac defect, you would see. But the interesting thing is, whatever screw has been put to address the labrum is still not damaged the face of the labrum. That means there is a role for arthroscopic revision of this patient. So here at arthroscopy, you see the huge hill sac defect. Like a gutted. So if the hill sac defect is huge, we might need to put 2 anchors to address the remplissage. So here is the top view. You see the labral tear, the quality of labrum because of the previous operations. So that's the extent of tear, extending from the superior labrum down to 6 o'clock. So here, the hill sac anchor, there's a remplissage anchor is inserted, and the sutures are placed from the posterior direction. And here it shows the inferior labral repair. So it's addressed posterior, inferior. So once you do that, this is the anterior labral tear on the top 2 pictures and the superior labral tear on the bottom picture. So all repaired. So this guy has got all around repair. So that is the final picture. You got the repaired hill sac, humeral head centered on the glenoid, and the anterior labral repair. So just to show him, that is a 2 months post-operative. Only problem, the external rotation won't be there because of the previous open surgeries. So role of open surgery, when I do, the indication is about 5% of cases in my practice. If the glenoid fracture is a big fracture or more than 30% loss of the bone loss, I do either fix the fracture or lateral J patty procedure. If the coracoid process is not available, use the iliac crust graft. For example, this patient had a 28-year-old central reserve police, had 3 surgeries before. Attempt at arthroscopic surgery, you see the 1 anchor there, and the open surgery, and also 3rd surgery with the coracoid procedure. So his coracoid is also violated. He's got anterior glenoid defect. There is only 1 operation to help him. It is a free iliac crust graft reconstruction of the glenoid with the repair of the labrum. That's what I did for him. A couple of screw fixation, and he put anchor and repair the labrum onto this. And that is him 2 months post-operative. So still there is a role for in arthroscopic as well as open surgery in a failed case, depending on the individual case selection. In conclusion, arthroscopic stabilization with the addition of capsular remplissage extend the arthroscopic indication and reduce the recurrence rate, becoming slowly the new gold standard in the expert hands. Thank you very much.
Thank you, Ram. Any questions? So it was an interesting analogy, ACL and the IGHL,
Because
actually, and it's so true.
Yeah.
But can I ask you, what is your cutoff for a first-time dislocator? What age would you?
30.
30.
The analogy to ACL I said because ACL is very popular and everyone jumps to replace, reconstruct. So I thought to put that slide.
So, and with a huge hill sac defect, would you consider sometimes doing a latache or would you just do a remplissage for all of them?
We have done mostly a lot of the patients with only remplissage now. So depending on the success, if we have a repairable anterior labrum, I go for arthroscopic remplissage plus repair. If there is also a glenoid problem, then I go for open lateral J patty.
Thank you.
Yeah,
So,
continuing with the analogy, how much time do you wait after the operation?
I do on the same admission.
Same admission.
Yeah, 2 days.
In ACL will wait.
I know. But the shoulder is a dislocated shoulder, and the soft tissue is not a big problem. It will swell a bit. I normally let them 2-3 days time in the hospital to take them decision and all.
They say reduce it.
Yeah. Wait for 2 to 3 days, and then the ice pack, and then arthroscopy, ice pack again. It will go down. But the operation has to be quicker.
thank you very much.
Thank you.
So we don't have the next talk on posterior shoulder instability because Dr. Parag Shah is not well. So we'll have Dr. Raman Agarwal from Delhi, who's going to talk to us on instability with bone loss. Extremely important to actually assess the degree of bone loss before you embark on planning for your surgery. So Dr. Raman Agarwal.
Good afternoon. That was an excellent disposition of the arthroscopic work where I'm from MEOTS. Now I want you to just focus on first few slides, as this technology and could be boring. But what is it which will make me decide what procedure to do? I will cite, I'm not getting into the controversy, but I will cite one surgeon, Jill Walsh, doesn't do arthroscopic repair. I do arthroscopic repair. He does letter J in all the patients. Has done more than 2,000 with a complication rate of 1%, recurrence rate 1%. But he has modified the letter J procedure and he is the originator. So expert hands. I've got a slide which will show the complications of this also. So let's come on to this. Glenoid bone loss is the most common cause of arthroscopic Bankart repair failure. Shown by Baulu, Begliani, Burkhardt, Gerber et al. They even did a biomechanical study and they found out that 21% of the glenoid loss decreased the stability by 30%. Itoye did an interesting study on a cadaver and he said it is not the width but the length also matters. And he said loss of 19% length, which is only 6 millimeter of the glenoid, will reduce the stability by a huge margin. And he also found out that it is not the anterior-inferior, it is the anterior, majorly anterior. So that was his study, which showed that the varying degrees of glenoid bone loss will increase the instability up to the 70% if we go beyond that, around 8 to 10 millimeters, that's gone. So when the patient walks in your OPD, what to do? He says, I've got, mera kandha utar jata hai. I've got a shoulder dislocation, has happened many times. So history is very important. So degree of disruption, the initial episode, frequency of dislocations, whether they are occurring during even underarm throw, that will give you a hint that he's got a bony instability. Occurring during sleep will indicate bony instability. Difficulty in reduction, bony instability because it has engaged and locked. Preoperative imaging, what treatment he has had, history of epilepsy will fail any stabilization procedure. Be very wary of putting your hands into an epileptic patient, will fail. History of alcoholism, drug dependency, and what are the demands? Slight bone loss, repairable labrum, small Hill Sachs, contact athlete, arthroscopic surgery might fail. Strong indications that even with less than 15% of the bone loss in contact athletes, go for an open stabilization or augmentation. So what do we examine in the patient? Hardly anything. But first thing is rule out the generalized ligamentous laxity by applying all the 9 Baton's criteria. Do check the cuff and the deltoid strength. Gage's test, hyperabduction. It's just like checking your Lachman. So when you hyperabduct the shoulder, if the contralateral side, the unstable side will abduct 20 degrees, difference should be more than 20 degrees, and you should have a firm end feel. The patient should be absolutely relaxed and he will have an apprehension of inferior translation, not easy to elicit. Apprehension we do elicit, sulcus sign is, we do check the rotator interval, but sulcus sign can again be an indicator of constitutional hyperlaxity, so beware. If the patient gets apprehensive even this range, 30 to 60, think of bone instability. And then load and shift test if you can elicit it in an OPD setting. So points to remember, painless anterior draw does not suggest instability. Patient could be congenitally lax. Apprehension plus relocation, they strongly suggest. Apprehension, when you do an ABER in increasing range of abduction, and relocation, you would make the patient lie on the couch, extend the arm at the shoulder, abduct and extend the arm. He will have pain anteriorly and apprehension anteriorly. You press the head of the humerus posteriorly, this goes away. You take your hand, pain comes back, apprehension comes back. So asymmetrical gaugey hyperabduction test is the most sensitive one, and most of the experts rely on this. Always check neurology for axillary nerve. Check subscapularis if you are in a revision setting, whether it is torn, what's the strength, and where are the scars. As I said, beware of constitutional hyperlaxity, beware of voluntary dislocators, and asymptomatic hyperlaxity is not instability. So don't be very happy if you are able to elicit the tests, but patient may not be actually symptomatic. So let's come to the imaging after history and clinical examination. So what X-rays, and this is the pitfall of shoulder surgery in our country, because we do not insist for adequate X-rays. Now, adequacy of imaging is the most important thing in shoulder surgery. So for Hill-Sachs, get your true AP view of the glenoid, or AP view of the glenoid, or true AP view of the shoulder, and then AP view in neutral, internal rotation and external rotation. Now he showed such a large Hill-Sachs, and you can actually find out how large the Hill-Sachs is if you get an AP view in external rotation and the defect shows superiorly on the head of the humerus in your X-ray film. You are looking at a very, very large Hill-Sachs. For glenoid bone loss, of course, axillary view, but it has been modified, and currently Banach views is the most important one. Very difficult to train your radiographers. Sometimes 3D CT scan is easier and patient friendly, and MRI and MR arthrogram also have their indication. This is the technique of Banach view. Patient is 70 degrees to the cassette and around elevated to 150 degree, and beam is tilted 30 degree caudally. That's how the Banach view would look, and you can appreciate you should be able to identify the sharp concave edge of the glenoid anteriorly and posteriorly. Any rounding will denote glenoid bone loss. So AP view of the shoulder is not equal to the AP view of glenoid. True AP would be, best would be Banach view of both the glenoids, oblique sagittal MR arthrography if you are asking for an MR, a 3D CT scan is the most important one, because then you can quantify the glenoid bone loss by a best fit circle for quantifying the loss. Now let us see what are the various experts across the globe they ask for the first line of imaging when the patient enters their OPD. Jeff Abrams from the US will ask for the X-rays. Jill Walsh will ask for the X-rays and the CT arthrogram. CT arthrogram because he wants to identify the soft tissue pathology, not only the labrum. He would also want to identify the rotator cuff. Herbert Reisch, he will only ask for a 3D CT, no X-rays. Baulot in France, less than 40 years, 3D CT, more than 40 years, 3D CT arthrogram to rule out a cuff tear. So in general, 3D CT, the oblique sagittal cut and face where you see the pear-shaped glenoid is the best view. And then if you can ask your radiographers to get both the shoulders, then you can have a fair idea and ask for the thinnest possible slice thickness of 0.6 to 5 millimeter. And you can also find out about the Hill-Sachs defect. And many surgeons would not do a remplissage beyond 30% of volume loss of the humeral head. But that's quite individual variation. He showed excellent work, but then he is a dedicated surgeon. Arthroscopic measurement using bare spot, Burkhardt told it, but I actually do not follow this. Reason being, I would have made my decision before taking the patient to the OT table, because I am doing instability repair, Bankart repair in a lateral position, and then changing from lateral to do a latarjet in a beach chair is a bit of a struggle. So I would decide preoperatively what I have to do. So there are many theories about the how to measure the glenoid bone loss. The best fit circle, Sugaya gave the surface area method, which is currently the gold standard. Burkhardt from the bare spot increased to CT scan, and then AP distance I'll show in the future slides. So this is the glenoid. So you can see the width is only 24 millimeter plus minus 4. You are looking at 10 to 12 millimeter of the radius of the glenoid. So anteriorly, if 6 millimeter is gone, you've lost 50% of the glenoid anteriorly. Gerber brought the attention that you must look at the length of the lesion as well. If it is starting, because most of the osseous lesions of the glenoid occur parallel to the line which runs from superior to inferior in the glenoid. They are not in the oblique plane. They are parallel to the superior to inferior diameter of the glenoid. And the bigger the length, the Gerber showed that if the length is more than the radius of the glenoid, shoulder is going to be unstable even after the Bankart repair. That's what he showed. Sugaya showed the best fit circle. You see, you calculate the surface area of the osseous fragment and of the glenoid. The inferior two-thirds of the glenoid is actually represents a circle, and the bare spot is actually 1.4 millimeter posterior to the central point. So it actually overestimates the bare spot is in front of the true center of the glenoid. And there have been studies, and few people do not believe, because they say that the bare spot method during arthroscopy overestimates the size of the osseous lesion. But the previous method of surface area needs sophisticated software from the radiology and great cooperation from your radiology colleagues. So an easier way, which you can also do on a CT, you can measure the distance and then take a ratio according to this formula, and you can calculate the glenoid bone loss. Bigliani classified the lesions: type 1 avulsion fracture with capsule attached, basically a bony Bankart; type 2 a malunited bony Bankart; type 3 attritional loss of the glenoid because of the recurrent dislocations. Less than 25, more than 25, more or less the word consensus is on 25. So reconstruction of bone loss, autograft from the iliac crest, and recently now they are coming from the distal tibia, allograft, Bristow procedure, Latarjet procedure, modified Latarjet. So what's the difference between Bristow and Latarjet? And there's so much confusion. Bristow was only tip of the coracoid put onto the neck of the glenoid with one screw. And they actually did it below the subscapularis originally. But Latarjet was a general surgeon who devised these Latarjet surgeries, Latarjet nerves for the stomach. Now he said full length of the horizontal part of coracoid 1.5 to 2 centimeter, inferior surface of coracoid transplanted, made raw and then transplanted to the neck of the glenoid, 2 screws used, and stump of the coracoacromial ligament, which is attached to the lateral border of the coracoid, suture to the lateral half of the capsule to reinforce the inferior glenoid. These are the essential components. I follow Jill Walsh. I don't do the Burkhardt modification of standing coracoid, but this also restores the congruent arc. So as Ram had shown, sometimes you do a Bankart repair because you think this patient is really high demand, but most of the times you don't do a Bankart repair, you just do a Latarjet according to the principles and come out. Now there are controversies. People could not start Latarjet because the previous literature reports reported 30% osteoarthritis rate, but there were complications because it was not done correctly. Now they have identified, and now people say, how does Latarjet work? It was 3 effects: osseous effect because it extends the glenoid bony arc, but it does not produce a block. Do not think that you are putting coracoid in front of the glenoid to block the head of the humerus from coming out. No, you put the graft flush, so you extend the articular surface of the glenoid instead of blocking any anterior translation. Ligament effect: stump of coracoacromial ligament suture to the capsule. Muscular effect: because you do it now with subscapularis splitting approach, so lower half of the subscapularis is shifted even down, and in position of abduction, this takes the root of the IGHL along with the conjoint tendon. But there are some doubts. Some people say the conjoint tendon actually helps. Some people say it doesn't. So what are the indications of Latarjet? Definitely glenoid bone loss more than 25, large hill sacks with little bit of glenoid bone loss, Lafont in France would even do a lateral in Hegel. Now he's one of very, very refined arthroscopic surgeons, and he still doesn't think that Hegel he can treat arthroscopically. Failed previous arthroscopic surgery, ligamentous laxity, I don't know. What will you do in ligamentous laxity? Could do lateral, but beware. It brings the musculocutaneous and the axillary nerves very close to the glenoid. This is the conjoint tendon. They are just on the medial border of the conjoint tendon. And when you bring the coracoid to the glenoid neck, all the nerves from medial, they are brought more laterally. So in a revision setting, this you could find this. They just beside the conjoint tendon, the nerves are lying there. So beware. Technical pearls for doing a lateral J. Avoid coracoid fracture. Use a 2-finger technique, push or 2K wires and then put 2 screws. Avoid lateral overhang. The coracoid should be flush to the glenoid. It should not come in front of the joint space. Avoid hematoma. Avoid non-union. Most important thing for doing a coracoid, get a good graft. Spend time. Get a good graft. Then spend time on making it raw with a burr. And then raw the anterior neck of the glenoid as well. Place the graft in the lying position and bicortical compression screws. Do not over tighten the screws. Avoid washers, or you can use washers if you have ample space. Avoid graft lysis. Do not use cautery beyond the tip of the coracoid. Come to the tip of the coracoid when you are taking the pectoralis minor from the medial border, but leave the tip. Do not use cautery at the tip of the coracoid. That is where the blood supply goes for a lateral J. Avoid stiffness and loss of external rotation because you are going subscapulary split approach, so you will avoid that. Avoid degenerative osteoarthritis because you will not allow any lateral overhang. Fatty infiltration of the subscapularis has been a concern, but not with subscapularis splitting approaches anymore. Avoid recurrent instability. Spend time on graft and making it heal. One of the cases, you have to expose the neck nicely and good graft all along the glenoid margin. But still it fails. When? Jill Walsh in 2000 cases said that only dislocators in his series of 2000 cases were epileptics and voluntary dislocators. But he has developed a meticulous technique and doing over the years, perfect technique. But things can go wrong. So uncontrolled epilepsy, as I said, instability with paralysis of deltoid, cuff, periscapular muscles, multidirectional instability with general ligamentous laxity and voluntary instability. These are the failures, provided you have done it correctly. Complications, neurovascular, 5-6 axillary artery injuries, 4 brachial plexus pathies in a case of 1904 shoulders across the world, 45 studies including meta-analysis. Recurrent instability was 2.9. Reoperation rate was 6.9. Graft lysis 3.2%. Coracoid fractures 1.5%. So spending time on the surgery and not listening to your anesthetists, that's the key. Complications, as I said, one complication I said, hardware migration. If you do it nicely and it heals nicely, hardware would migrate, because instability at the graft and glenoid side would lead to hardware migration. Now I come to the last topic, which is the management of humeral defects. Humeral osteotomy. Basically, we are talking about Hill-Sachs now. We've dealt with glenoid. Allograft reconstruction, remplissage, transhumeral bone grafting. One of my patients, 8 months old, locked posterior dislocation. Just to bring home to your notice that it is the reverse Hill-Sachs which needs to be dealt with. No amount of soft tissue procedure would allow the stability. So did an allograft reconstruction. That's how the patient X-ray looked later on. That's the pre-op, that's the post-op, that's the pre-op, that's the post-op, without any physiotherapy. This patient was from international services and came only after 7 months. I think remplissage has been shown beautifully. I'll skip this slide. So I come to the end of this. What do we do? You have 0 to 15% of bone loss, and we are talking about 4 millimeter of anterior glenoid. 4 millimeter could constitute 15%, 4 to 5 millimeter could constitute 15%. It is not only the width, AP, but it is the vertical damage, vertical length as well. So if it is 19% vertical length, it's gone. So yes, soft tissue stabilization, bone loss may be ignored, less than that, maybe up to 3 millimeter. You could go arthroscopically, try to find the fragment and incorporate it. But consider posterior repair in contact athletes, and Ram has shown it beautifully. It depends on the demand. 15 to 25% bone loss, find the fragment. If you can find the fragment and you can't fix it arthroscopically, open, fix it, and repair the Bankart. If you can't find the fragment, you may consider bone augmentation, because that's a borderline thing now between 15 to 25. You can't find the bony fragment. Then you have to depend on what is good in your hands. You can go either way. No doubt, if the loss is more than 25%, augment, augment, augment. So take home message, detailed history and clinical examination, get oblique sagittal views on 3D CT of both the shoulders, put it into your practice, you will pick up much more cases which you can deal if you can't do the arthroscopy. Each 1.5 to 2 millimeter of bone loss amounts to 5%. So 3 millimeter could be 10, 4.5 millimeter could be 15%, you know. Meticulous bone graft preparation for the latter day. Thank you for your attention.
Thank you, Ram. Any questions?
Yep.
Sir, for any bony bankers, is it possible to find out a bony lesion on an X-ray? And if it is possible, if you can find a 20% bony defect on an X-ray, then would you go for a CT scan, or you would routinely go?
I can never be sure of that bony fragment on X-ray. I can never be sure of the dimensions of the bony fragment on an X-ray. I can be sure of glenoid attritional loss on a Bernard view. But if I'm looking specifically for the fragment, no, I'll have to go for a CT.
So my question is, would you primarily go for a CT scan, or
I would
first go for an X-ray, and only if you suspect a bony loss, then
Okay,
you would go for
what I do is, I showed you a slide what the experts are doing across the globe. But in my practice, what I do is, I always get a true AP, axillary, and the scapular value of the shoulder in all patients, irrespective of the disease. So in true AP view, if I find that the sclerosis coming from the anterior margin of the glenoid and it loses its sheen midway, I'm looking at a bony fragment.
Only then you would go for CT scan.
No, I still go for a CT scan, because things are not that easy. If they were that easy, there wouldn't be 5 surgeons developing 5 methods.
Then would you suggest a CT scan as a primary?
I would suggest yes, if you are considering a proper evaluation. Yes, there are times when you need to rule out a Hagel lesion, so MRI is needed. But I would say, if in doubt and you are suspecting soft tissue pathology, then CT arthrogram is my first choice. Instead of MRI, no MRI, CT arthrogram.
So I think that increasingly the trend all over the world is to actually get CT arthrogram rather than an MRI for suspecting any bony lesions.
And it becomes so easy as
It's
a
become
because
easy
you know,
to-
for the
yeah.
radiologist, he can put the needle and conform it into the CT guidance and then inject the dye, and no extravasation. But MR arthrogram, they don't take the
can't do
patient to
that.
the CT scanner first and put the needle. That's a practical problem.
Very true. So many times you would, come out thinking you've done a fantastic Bankart repair, but and if it fails, you wonder why. It's because you haven't actually looked to detect any, bone loss, mainly, glenoid erosion. So thank you, Raman, once again.
Thanks.
I now call on Dr. Swarnendu Samantha from Calcutta. He's going to talk to us on slap lesion and the throwing athlete.
Respected chairperson and all my friends, this is a great privilege as Moyes has invited me for this forum. My talk will be slap lesion and the throwing athlete. So history, if you go into the history of the slap, it was the slap, Snyder coined the term the slap superior, lateral, anterior, posterior, Andrews told pull off mechanism. The biceps, if we consider the anatomy, The anterosuperior stability is given by the biceps, preventing the torsion and migration in extreme of abduction and external rotation. So before going into the slap, we have to understand this kinetic chain of the throwing motion. It is all early cocking, late cocking, acceleration, deceleration, and the follow through. So your ground leg and the trunk is basically the force generator, and the funnel and the force regulator is the shoulder, and the arm is the delivery system. The key elements in the chain is your body rotation, timing, and the scapula's position, because very, very important is the scapula. And as you go into the hyperabduction and external rotation, you have to compromise your mobility and stability. That's why it is known as the thrower's paradox. So if we consider the cocking phase, in early cocking, the posterior deltoid groove is the main muscle, and in the late cocking, your peak muscle activation is the supra-infra and the teres. And in this phase, the associated pathologies are like your internal impingement and the glenohumeral internal rotational defect or deficit. In the acceleration phase, when you go like this, triceps is the early muscle, then the late activation group is the pec major, latissimus dorsi, and the serratus anterior. And in the deceleration phase, if you go like this, is the most harmful phase in the throwing athletes. The eccentric contraction of the muscles, and the associated injury is mostly the slap, the biceps tendon injury, brachialis injury, and the teres minor injury. Pathomechanics, as Snyder told, in the acute trauma it is fall on the outstretched hand. And the chronic group, if you consider the Andrew, it is high eccentric activity of the biceps. And Barker and Mongar is a peel back mechanism, and Pradham is the increased superolabral strain during the cocking phase. So shortly, in the acute trauma, it is a compression of the biceps between the glenoid and the humerus, traction mechanism when releasing the ball, and the peel back mechanism in the late cocking phase, maximum external rotation and abduction. So this is the slide from the Barker's, your Snyder's original article. Is the compression of the biceps between the glenoid and the humerus. Traction mechanism. This is the, so in the late cocking phase, the biceps is pulled like this because of the eccentric this is the deceleration phase, is like that. So it pulls off your labral attachment. And the peel back is given by the Barker's theory, is occurs in the extreme of abduction and external rotation. This whole thing, if you go into the hyperabduction and external rotation, whole thing peels back. So in the late cocking and the early deceleration, if you see from the back on the top, your biceps, you see the biceps is like this. In this phase, the biceps is like this. And if you, in the early deceleration, biceps go all along in the front. So if we consider the slab, it is not only the one mechanism, it is your traction, instability, and the peel back. So all 3-4 mechanisms are involved to create the slab. So mechanism of injury, baseball, this like the throwing athlete, late cocking and the deceleration phase. And the mechanism of injury like your capsular contracture, is the slap to posterior. Given by the Morgan's theory, slap to posterior is the most common one in these throwing athletes. When you consider the slap, this article is very famous article by Grossman, because when we go with the hyperabduction and external rotation, the humeral head translates like this, and because of the posterior capsular contracture. So native shoulder head shifts posterior inferiorly in the late cocking phase, but with the posterior contracture, this is the most important slide, the head shifts posterior superiorly because of the posterior contracture, and there is labrum under tension, external rotation, labrum peels back. If you go into the article review, Paganani article, complete slab in the glenohumeral translation, then Schem's theory of biceps activity. Andrew et al., they found that the partial articular surface tendon avulsion is up to 45% of their patient series. And you can find this article, Snyder's article, this much of complete rotator cuff, pastal lesion, and the Bankart lesion. So in type 1 slap lesion, you will find the rotator cuff. In type 2, in the older group, you will find the rotator cuff, and the younger group, you will find the instability. 3 and 4, instability again. So tightness of the capsule and the anterior laxity, when you go with the scope, you have to find this. This is the all routine classification. The article, the Snyder's article 1, 2, 3, 4. We are not going to the detail of that because you all know that. Then the Morgans, then the Nord, they have extended the classification like your anterior Bankart, then flap, then superolateral, and these go like this, posterior, whole, and this goes into the rotator interval. So symptoms is vague shoulder pain or during dull throbbing pain, complaints of cocking, clicking, popping and snapping, difficulty sleeping at night, and pain particularly in certain phases of throwing cycle. Pulling through in swimmers. So what is the difficulty in this? The pulling through in swimmers, making contact with the ball in racket sports and releasing the ball in throwing. Clinical test, as we know, speed, compression rotation test, O'Brien and Job. The diagnosis of SLAP by clinical test is very difficult. So if you find that two of these tests are positive, 89 to 90% that you can find the SLAP is there. So speed and O'Brien is mainly for the anterior SLAP, and the Job is mainly for the posterior SLAP. Pre-SLAP, this is also very important in the throwing group. Tightness of the back of the shoulder, patient still I am not getting loose. Shoulder at risk, you can find the glenohumeral interrotation and the sixth scapula. If the interrotation deficit from the contralateral side is more than 20 degree, total range difference is 5 degree, then you must find that this degree is there, and you will find as a SLAP at some point of your career. Then you have to test for this scapular stability, the scapular assistance test, and the scapular retraction, because the scapula, if it is not proper and the muscle balance is force couple is not there, the throwing athlete will have SLAP at some point of time. So this is the correct technique. You see, the humerus should be in the plane of the scapula. If it goes back, the elbow will drop down. MRI, you have to find the SLAP, and for the SLAP you have to take the ABR view so that you can find the SLAP properly, and you have to find the pasta lesion. And another one trick of this is the normal one. If this lesion, it is going like with parallel with the glenoid, is not a SLAP. But if it is not parallel, then only it is SLAP. It can, sometimes the sublabral hole can be thought like for a SLAP. The Oreo cookie sign. There is the Oreo cookie sign for the type 3 Snyder. So every time you have to, when you examine for the throwing athlete, you have to diagnose them in the pre-SLAP stage. Rest analgesic, then strengthening exercise. This is very, we have to harmonious effect of the scapulothoracic muscle group. Operate in young group, high demand and failure of conservative treatment. So you have to go for the operation. Type 1, we know the debrided, fix it for type 2. Type 3, only the buckle handle excision, most plus minus fixation, and type 4, debrided, if his age is less than 30, fixation. Surgical steps, you have to have the bleeding bone, denude the bone, fix it. And the most important thing is that when you do the SLAP, you please don't over tighten it, not away from the joint. Rehab is very, very important. Anatomy to heal, sling for 1 month, restoring range of movement, regaining strength. This is the technique taught by LaFo's last meeting. Take just 6-inch stockinette, give on 400 gram cotton, you can abduct the arm for your cuff and SLAP. So diagnosis is always a challenge. Please remember that peak at the pre-SLAP stage. Type 2 posterior variety Morgan is the most common type in the throwing athlete. Try conservative, because if you can pick them, try conservative. Most of the time you will be successful. And don't over tighten. Thank you very much for your kind and patient hearing.
Thank you, Swarnin. Any questions? So what is your conservative line of treatment?
Mainly, if you can pick them up in the pre-SLAP group, then you have to strengthen your capsulothoracic muscle group and your deltoid, biceps, everything. You have to teach the proper technique, because if the elbow drops down, and if it is not in the this is not in the plane of the scapula, then you have to strengthen the scapular muscles. So you have to primary test the scapular assistance test and retraction test to know that whether the scapula is the sixth scapula or not.
So there is a case for actually screening athletes who are in active
there is a
sport
lot of study. If you go to the literature review,
Absolutely.
if for the full year they are studying their scapular system, because unless you pick them up in the pre-SLAP stage, even if you do the surgery, the high demand pitchers, they are never going to get. Even it is reported like 70%. If you go for the surgery, 70% of the patients they are not going to the level they were previously.
Okay. And what is your cutoff age for a slap repair versus a biceps tenotomy or a tenodesis?
The biceps sterotomy and tenodesis is a big topic, you know.
Yeah.
because-
No. What is your
because
cutoff age? Because a
with
lot
30 years, if it is an
30?
active group, 30 years, if it is only slap lesion sort of thing, is type 1 to 4, still I will fix it. Only if it is a biceps is frayed more than 30%. This is even in the literature that the biceps tendon is frayed with the slap, it is more than 30%, then you can excise that part of the biceps. But if it is more than 30%, you have to fix the biceps, or you can go for the tenotomy and tenodesis.
I have got a question on this. I have been never be sure of my 30%. If the bicep tendon is frayed and there is a slap, then I will be, because I'm not too sure, then I can relieve the pain of the patient.
Yeah, that's why I'm telling, because if the biceps, suppose the fraying is very less, you can excise that part of it. But if it is really frayed for a, most of the biceps is frayed, you have to go either for, if it is age is more than 50, 60, you can go with the tenotomy. But if it is a year like 40, 50, you can go with the tenodesis.
Okay, thank you very much.
Thank you.
I now call Dr. Nitin Bejanki from Hyderabad. He's going to talk to us on current concepts in treating adhesive capsulitis.
CGMS, which Dr. John is going to talk about.
Is there any more questions? Otherwise, we'll go to the next session. Thank you very much. Yeah, 1 minute. As a token of appreciation, I request Dr. to hand over, Mohan Varghese to hand over the mementos to the speakers. This is, yeah. This is Sanjay Reddy. Thank you. We go on to the next part of the same